Like comfortable, like you can look at it. How many of you are comfortable with blocks? Heart blocks. All right. So we're going to cover heart blocks today. All right. So what we're going to do is we're going to look at one, and then we're going to look at the different heart blocks, and we'll try and simplify them. All right. Okay. So heart blocks are quite common. We see them almost every day. All right. So this is the ECG that we're going to analyze. I'm going to make it bigger just now. All right. So whenever you're analyzing an ECG, this is the way that you do it. All right. So you first look at the axis, then you look at the rhythm, then you look at the rate, and then you look at the zones. All right. Now, if you're confused or if you don't understand any of that, have you guys got access to the learning group? No. And online? Okay, I'll show it to you all after this. All right. Then you can just take down then there's a whole series of lectures on the ECG basics. Okay. All right. Okay. So let's go through this ECG then. Okay. So what we have is a 53-year-old woman with lightheadedness. Okay. So first of all, let's see, how did we get to the point of deciding to do an ECG? I mean, this is a 53-year-old with lightheadedness. Why would you do an ECG in an emergency department?
Patient there for it.
Nothing. She's just lightheaded. That's it. So the ECG wouldn't be your first thing, isn't it? That's the thing. All right. So if you were sitting at home and somebody phoned you and said, please come, we've got a 53-year-old lady with lightheadedness, what would your mind be thinking of as you're coming towards the emergency department? You'll be thinking about sugars, BPs, you'd be thinking about all the other vitals. Is the patient hypoxic? Does the patient have carotid illness, cardiac illness, things like that? But cardiac illness would come into it. Agreed. You would think, okay, maybe there's something cardiac. So eventually it might lead you to doing an ECG. So you do the ECG and this is what comes up. Are you scared? Scary, isn't it? It's scary because if you look at the ECG just in total, it's a scary ECG. So break it down into little parts, all right? So that's the easiest way to analyze the ECG. Okay, don't try and find a diagnosis immediately, because as soon as you try and find a diagnosis, the first thing you'll do is get it wrong. Seriously, you'll get it wrong because immediately you start looking at the wrong thing. So first of all, we look at the axis. Who knows how to get the axis on an ECG? All right. Yeah, we look at leads 1 and AVF. All right. So they're both pointing upwards. Yeah, we look at the QRS. So they're both pointing upwards. All right. So there's a lot of methods to do it. But in this case, it's a normal axis. Okay. We're not going to stress too much about it. If you want to see how to, like I say, I'll show you all at the end. All right. Those lectures that you can look at. All right. Now let's look at the rhythm. So there's 5 components to rhythm. Okay. So it's the P wave. What's a P wave? Your atrium. All right. Then it's your PR interval. What is your PR interval? It's the time between your atrium and your ventricle contracting. All right. Then it's your QRS complex. Is it narrow or wide? Narrow is normal, wide is bad. Okay. Does a QRS come after every P? In other words, does a ventricle contract after the atrium? And then the PQRS, are they regular? So in other words, rhythm is lub-dub. When you're small, you learn the heart goes lub-dub. So all you're trying to make sure is that the heart is doing lub-dub, lub-dub, lub-dub. You're making sure the heart is not doing lub-lub-dub-dub. It's not doing lub-dub-dub. You get what I mean? So that's all that you're trying to do. That's all that rhythm is. So let's look at this, all right? So let's look at the P waves. So have we got P waves? Yes, we do have P waves, all right? They're relatively normal, all right? Oops, sorry. It was a mistake. So what about the PR interval? What do we see? So what's the normal PR interval? It's between 2 to 4. 2 to 4 small blocks, all right? So less than 2 is a problem, more than 4 is a problem. Okay. So in this case, let's look at the first PR. We've got about 1, 2, 3, 4. So it's borderline, all right? And what's the next one? Yeah, it's about 7 blocks, all right? And we look, that's quite consistent everywhere. It's short and then it's long. It's short and then it's long. So it's a PR interval that's growing. So it's already not a normal rhythm. There's something wrong. So what we have is instead of lub-dub, we have lub-dub, lub-gap, dub. Do you get what I mean? So it's already, there's something wrong with that. Okay. Now we don't have the full rhythm strip over here, but we can already see something is happening, right? Something is going wrong. Okay, then we look at our QRS complexes. Are they narrow or wide? They're narrow. All right, except for these ones. Okay, but we'll get to that just now. And what you call it? Are they regular? No, they're not regular, because in between you've got these beats that are coming out. All right. Okay. And does it occur regularly? It doesn't occur regularly. So this is a rhythm disturbance. Right, so we've got a rhythm disturbance. So we can look at rate as well. The rate is about 1, 2, 3, 4, 5, 6. So it's 300 divided by 6. So it's about 55 to 60, somewhere around there. There's no ischemia in this. All right. So we won't get into that now. It's a whole other discussion. All right. Okay. So if the PR interval is lengthening, is becoming longer and longer, there's only one heart block that does that. That's Mobert's type 1. But we're going to discuss all of them just now, right? So this is a Mobert's type 1. But what's more interesting in this one is these beats that are coming out. So what's happening with these beats? You got a normal QRS complex, and then do you have a P wave before this? If you look everywhere, you know, it's a T wave and then a wide QRS complex. So a wide QRS complex is something coming from the ventricle. So it's an ectopic beat, but the question is it ectopic from the atrium or is it ectopic from the ventricle? Is there a P wave? No. So is the atrium involved? No. So it's an ectopic ventricular beat. Do you guys see? Or premature ventricular contraction. Do you understand how you get to that point? Okay. Shame, Doc, you're looking scared. All right. So let's say you did have a P wave inside here. All right. So you had a P wave that came out of nowhere, and then you had this. You could say that that was maybe a premature atrial contraction. No, not really, but I mean, technically speaking, you would be correct. But because there's no P wave, in other words, the atrium is not contracting. The ventricle is just contracting on its own. So it's an ectopic ventricular contraction or premature ventricular contraction. So is this patient in trouble? Yeah, there's something going on. Are you the cardiologist? No, you're the emergency department doctor. Are you going to rush this patient to ICU? No. But are you going to ask the physician or the cardiologist to have a look? Yes. Okay. Are you possibly going to do cardiac enzymes? Yes. Because one of the reasons for heart blocks and things like that is ischemia. So there may have been ischemia before then. Is the patient going to be admitted? Yeah, depending on what's going to happen. And that's the end of your involvement. You don't have to treat this patient. You're not going to do their follow-ups. You're not going to do their stress ECGs. That's the beauty of working in the emergency department. You know there's something wrong. You picked it out. You save the patient. You get a prize, and you get to go home. The cardiologist has to sit until 12 at night to figure out if this is something serious or not. Okay, so that's the good part about it. So let's look at the answer for this one. All right, then we'll look at all of them. All right. So we've got a second degree AV block type 1, all right, which we'll get into just now. Frequent premature ventricular contraction in a pattern of ventricular trigeminy, which means it comes every third beat, basically. Okay. The rate, yeah, is about 73, non-specific T-wave flattening. That's about it. Okay. So this goes into more detail about it. I don't want to get into too much detail about it, but let's look at the different types of heart blocks. All right. So let's look at this heart block and let's see what's going on. All right. So we're not going to worry about rate and axis and whether there's ischemia. We're just looking at the rhythm, nothing else. All right. So here's our rhythm strip at the bottom. So do we have P waves? Okay, we do have P waves. What about our PR interval? Is it long or short? It's long. All right. Is it consistently long? So it's always long. All right. It's more or less the same. All right. Right throughout. Our QRS complexes, are they narrow or wide? Okay, they're borderline. All right. But that's not important. Okay, it's actually a left bundle branch block. We won't get into it. Let's just say they're narrow for argument's sake. All right. And are they regular? They are regular. So what's happening? Between the atrium and the ventricle, sorry, there's a delay. There's a delay. That's about it. But that's it. There's nothing else happening. So in terms of severity, is that very bad or not too bad? It's just a delay. That's it. I mean, you compare it to the last ECG that we had, not actually that bad. So what do you think? Is first degree, second degree, third degree? First degree. Very good. So first degree heart block, PR is lengthened. Consistent. It's just lengthened. So what it means is that from the SA node to the AV node, in that atrioventricular septum where all the pacemaker cells sit, there's something that's gone wrong there. Now, you can't tell what exactly from this, but you know there's something wrong. Is this patient at risk of something else going wrong? Yes. So this patient at some point needs to be seen by a physician, cardiologist, things like that, all right? So a lot of the times this is just an incidental finding, unless there's symptoms. Okay, if there's symptoms, then we do get worried. Okay, all right, let's look at another one. So let's look at these two, all right? So again, do we have P waves? Yes, we do. All right, let's start with this. So how this PR interval, how does it look? A little bit long. And then this PR interval? And then what happens here?
There's a miss of QRS.
Yes, very good. So we have QRS, QRS, and suddenly no QRS, all right? So if we had to analyze it completely, we've got normal P waves, we've got a PR interval that's getting longer and longer. We have narrow QRS complexes with a misbeat, all right? And then we see the cycle starts again. PR getting longer, and there it's going to miss. Okay, so now what's happening? It starts off normal. Okay, the conduction is normal. And then it just gets a little bit worse. And then it just gets a little bit worse. And then it really gets bad. Okay, but it's still getting through. So what do you think? Is this good or bad? It's bad, all right? So this is what they call a Morbitz type 1. The easiest way to remember it, Morbitz type 1 is the only one where the PR interval gets longer and longer. That's it. Okay, so if that happens, it's Morbitz type 1. So when you do your ACLS, whatever it is, just remember, PR interval getting longer, doesn't matter what's happening with anything else, Morbitz type 1, all right? Let's look at the second one, all right? So here we have our P waves, all right? Not the best example, but it's just to give you an example. So we have a PR interval, and then what do we have? A miss. And there we see another miss. And, oh wait, this is the wrong one. No, wait, hold on. I just want to see it. This is this is something else completely. Yeah, this is the one that no. Okay. I think I put the wrong one. Oh no, this is this is the correct one. Sorry. So it's a PR. We see a PR interval, all right? QRS complex, PR interval, and then a miss. So in this case, a PR interval is slightly long. It's borderline, but it's consistently long. And then you get a miss. This is Morbitz type 2. Okay. No, it's no problem. So in Morbitz type 2, you have a consistently prolonged PR interval. Morbitz type 1, it gets longer, drops. Morbitz type 2, it's long drops, long drops. So what that means is that it's never normal. In Morbitz type 1, it's normal at some point, and then it gets worse and worse. In Morbitz type 2, it's bad from the beginning. It stays bad, and then eventually it's dropped completely. So what's the problem with Morbitz type 2? These patients are at high risk of complete heart block. All right? You never send these patients home. These patients will often have symptoms. Patients have often had ischemia or damage to the heart in one form or the other. What you do with a Morbitz type 1, you would refer. It depends on the symptoms as well. So if the patient is severely ill, of course, then that could be the cause. But there's lots of reasons why. I'm just trying to give you because it's nice to see it, but what do you do with it? You know, it's like chasing a car. Okay, you caught the car. Now what do you do with it? You know, you need to be able to know what to do. So Morbitz type 1, you refer. Morbitz type 2, you refer, right? So let's get to the last one. So this is obviously third-degree heart block. Okay, so what is third-degree heart block? Third-degree heart block means there's no relation between the atrium and the ventricle. Okay, now this is not the best example because normally you get wide QRS complexes, but it's just to give you an example that it can happen like this. But let's look at the atrium. Can you see those P waves? They're regular, agreed. But are they related to the ventricle at all? Not at all. And here's your ventricle. Is it regular? It's regular. It's regular, but is it related to the atrium? Not at all. So that means between the atrium and the ventricle, there's no relation. So it's a complete heart block. Got it? Okay. So what's the problem with these patients? Number one, they're bradycardic. Why are they bradycardic? SA node is firing. It's telling what to do, but it's never reaching the AV node. Okay, it's kind of like you calling me for pulmonary embolism, but I never answer you. I never answer you. It's a complete block between the two of us. You'll still make decisions on what to do, but it will take you a bit longer. So that's what the AV node does. The AV node sees nothing's coming from above. It's looking for answers all the time. There's no answers coming. So it has to eventually do the work by itself. But it cannot do the work at the same pace as the SA node. So it does it at a much slower rate. So look at this patient. 1, 2, 3, 4, 5, 7, 8, 300 divided by 8. So you're looking at about 40 beats per minute. Okay. So is this patient bradycardic? Very bradycardic. Are they going to be symptomatic? Depending on how bad it is. What do you do for this patient in the emergency department? It depends on how symptomatic they are. All right. So bradycardia is its own discussion on its own. You'd either give them atropine, adrenaline, you'd pace them, but you're not going to send this patient home. This patient is at high risk of developing further arrhythmias, severe bradycardia, may need ICU. Okay. So let's just recap it one more time. So first degree heart block, PR interval is long, right? But it just stays long and nothing else happens. All right. Morbid's type 1, PR interval gets longer and longer. Eventually, a beat will drop. Sometimes, I know in the ACLS exam, they throw in one where the beat doesn't drop. Everybody panics, yeah. Everybody panics because now they don't know the answer, right? The PR is getting longer, Morbid's type 1. Okay. Morbid's type 2, PR is long, and drops. Long, and drops. And Morbid's type 3. Grade 3 or complete heart block, there's no relation between the atrium and the ventricle. Now, the one other way to remember it, normally the QRS complexes are wide, all right? Why is it narrow in this case? All of us can have what they call ectopic pacemaker cells. So in your heart, you can have pacemaker cells like the SA node that nobody else has. It's unique to you. And they actually give the signal to the AV node. This happens a lot. You get, it's more common in tachycardias. You've heard of Wolff-Parkinson's-White syndrome? That's where that comes from. So you have ectopic pacemaker cell. So this particular patient has an ectopic pacemaker that's going at a slower rate. So technically the AV node is getting instructions from above. It's just the wrong instructions. It's kind of like you ask Dr. Somo about a pulmonary embolus. She's giving you the answer, but it's not the right answer. Nothing against Dr. Somo, but she doesn't deal with pulmonary embolus in the emergency department. You get what I mean, all right? Please don't go ask Dr. Somo about pulmonary. It's just a joke, all right? So you understand that those are the only types of heart blocks that you get, all right? Now, of course, what we're more worried about is what happens. What is going to happen to this patient? So most of the time, these patients do require intervention. Most of the time, these patients do require something because they've come to an emergency department. There's something going on. They're lightheaded, they're having palpitations, they're feeling weak, everything else looks fine. My honest belief, having worked in this department for a long time, if a patient comes in with a medical problem, just do an ECG. 90% of the time, you'll find something wrong. Not trauma patients. Somebody broke their ankle, please do not do an ECG. But if they come in lightheaded, palpitations, even for headaches, you'll be amazed you do get things that show up on ECGs. And the good part is now I think you don't even have to do your ECG. Somebody comes to do it. So order, keep the person here the whole day, just do it. And you'll be amazed, you'll find some amazing, okay, not today, from next week, okay. That's just a joke to finish off, right? So anyway, so I hope you'll understand, all right? So in our patient, what we had was two things, all right? If we look at it, we had what you call second-degree heart block, Morbid's type 1, plus we had premature ventricular contractions, and she was complaining of lightheadedness, and she's only 53. So that means when those premature ventricular contractions were happening, there wasn't enough blood. In other words, the contraction was not hard enough. So she's not getting sufficient oxygen supply, all right? So she's basically becoming hypoxic, brain hypoxic. There could be other things. She could have carotid stenosis, she could have aortic stenosis, there's lots of other things, but the fact that there is a premature ventricular contraction means that there's something going on. She needs further investigation. Would you send her home? No. You'd call the physician and you say, right, you make a decision. Okay, that's basically it. Okay, got it. Right. Any questions? Seriously, you can ask, no problem. All okay.
We always treat the bradycardia for the complete heart block.
Right. So bradycardia treatment depends on the symptoms. So if your patient is asymptomatic and you find that, no, you wouldn't treat it. But the chances of your patient being asymptomatic are very low. All right. So what's the problems with bradycardia? The problems with bradycardia is that your heart itself is not receiving sufficient blood. So you'd have symptoms of ischemia, low BPs, acute heart failure. What's the other ones that you get? Just slipped out of my mind. But there's normally 5 things that we look for. But the most common is low BP and ischemic pain. All right. In those cases, yes, you have to treat those patients. Question is, how do you treat those patients? That is a whole lecture on its own. All right. But the most common ways to treat them: atropine, if you have a narrow QRS complex. All right. So atropine is the most common. All right. Why we say atropine for narrow QRS complex? Atropine goes to the vagus nerve and tells the vagus nerve work. The vagus nerve tells the SA node work. Okay. So in other words, it's telling the atrium to beat faster. If you have a wide QRS complex, that means the atrium is not involved. So you can give atropine as much as you want. Atropine goes to the vagus nerve screams at the SA node. SA node is working, but that's not where the problem is. So if you have a wide QRS complex, then you'd have to use adrenaline or you'd have to use electrical pacing. Okay. So that's basically how you treat a bradycardia. But 99.9% of the time, if a patient comes in with that, yeah, we will end up treating the bradycardia. Okay. So atropine, 5 milligrams, given at 5-minute intervals until you get a response. Okay. Not 5, 0.5. Sorry. Please do not give 5 milligrams. That's 10 vials. All right. 0.5 milligrams. All right. How do you give adrenaline for bradycardia? 1 amp in 200 mils at 10 mils per hour. Okay. How do you pace the patient? Have to have a whole tat on that because there's a whole way to do it. But basically, you have to put the machine in pacing mode. You have to place your pads. You have to get electrical capture, physical capture. There's a whole way to do it. We'll try and do it one of the days, hopefully. All right. We'll have like a practical tat on it. But good question. It will be very rare that a patient with a complete heart block will be asymptomatic. Okay. But do you have to rush to get the patient up to completely normal? No. You just have to improve the heart rate a little, but that's about it. Okay. Any other questions? Sure. Okay. No problem. No problem. So,